Good morning. Hello, Dr. Bob here again. And we're working on understanding chronic disease, and we're discussing cardiovascular disease. And if you stuck with me through the last one, we talked a lot about coronary artery disease and cerebrovascular disease, a little bit about microvascular dysfunction, how the small blood vessels can impact your health as much as the big ones that can cause huge events like strokes and heart attacks. And it's probably a good segue into leading into discussion of a term that probably most people are familiar with, hypertension. So hypertension is blood pressure that is chronically elevated. Not necessarily chronically, you can have acute hypertension as well. And hypertension can lead to accelerated cardiovascular disease. It increases the risk of both stroke and heart attack. It leads to organ damage. Also, as time goes on, one of the leading causes of kidney failure. And hypertension is really an intertwined thing because it's kind of a cause and an effect. So, for example, big part of blood pressure and hypertension is going to be genetic. I mean, there's these evil humors, to just make it more simplified, that can be in your body that increase blood vessel tone, causing the arteries, the muscular structures in the blood vessel system to squeeze down and increase the blood pressure through chemical mediators that are released in various ways. Some are neurologic, some come from the kidneys, for example. And so there is a genetic predisposition, but there are definitely a lot of lifestyle factors. When we talk about obesity, for example, it's known that for every 10 pounds of additional adipose or fat tissue that you carry around, your systolic blood pressure, which is the big number on top, goes up about 5 millimeters of mercury. So the systolic blood pressure is the blood pressure associated with the contraction of the heart, which drives pressure in the system up. And the diastolic blood pressure is the blood pressure during the relaxation phase of the heart as the blood's sort of moving through the system. So you're in the contraction phase for about a third of the time and the relaxation phase for about 2/3 of the time. And we talk about mean blood pressure, which factors that in. But most of the time when we're talking about risk predictors and stuff, we're primarily worried about the systolic blood pressure, though either number, when elevated, is dangerous. And the ideal numbers, what we consider normal blood pressure, is a systolic blood pressure less than 120 and a diastolic blood pressure less than 70. And 130 to 80 we consider borderline, and over 130 over 80 is now considered hypertension. If blood pressures are extremely elevated and there are associated symptoms like neurological symptoms or chest pain or shortness of breath or some other overt evidence of end organ damage, we call that a hypertensive crisis, and that's something that we usually intervene with medication in an emergency room setting. What else is going on with high blood pressure? Well, part of it is, like I said, at the microvascular and even the larger blood vessel level, we are stiffening our arteries. This process of atherosclerosis as we age, that's happening. It's part of the aging process. And again, all the things that we talked about earlier and what we're going to go into in great detail can affect how quickly that process of atherosclerosis occurs. So if your pipes are getting thickened with arterial disease and calcified, obviously they're not going to expand well when that big pressure increase occurs during the cardiac cycle and the pump squeezes down, so that systolic blood pressure is going to go up. So that's, in a nutshell, a little bit about what hypertension is. It's elevated blood pressure. It turns out that it's probably most important that your blood pressure be normal while you sleep. Recent scientific evidence suggests that is a blood pressure issue that we should be most worried about. So I do like to see people measuring their blood pressure at night, right when they get in bed, and in the morning when they wake up, because I can probably extrapolate that's pretty good representation of what your blood pressure is while you're sleeping. When we finished up a little bit about hypertension, the cardiovascular system, just trying to go over basic disease, I would have to also start to talk about another subject that unfortunately many of you are already familiar with or are going to become familiar with, which is arrhythmia. Arrhythmia is when the heart does not beat properly. Generally, when we are in good normal health, we're said to be in sinus rhythm. Sinus rhythm is when the heart conduction is occurring from an impulse generated by a part of the heart in the atrium, the top part of the heart, called the sinus node. Now, sinus rhythm can be slow, less than 60, which probably is occurring in me right now because I have a pretty slow heart rate. I have sinus bradycardia, but that's from a healthy status. It can be normal sinus rhythm, which means somewhere between 60 and 100 beats per minute. And it can be sinus tachycardia, which would happen if you were exercising, for example, and would also be an example of a normal rhythm. At times, other areas of the heart can generate pacemaker function, and I'm just going to discuss a few of the big ones. Now, the most deleterious one is a condition called ventricular tachycardia or ventricular fibrillation, and this is common in the setting of when the heart is not getting adequate blood flow, the condition that we call myocardial infarction. If a piece of the heart muscle dies, oftentimes it causes a thing called a reentrant rhythm, which can lead to sudden death. And in fact, about 25% of heart attacks present with sudden death, which means that the heart beats so quickly from an impulse generated in the ventricle, the bottom part of the heart, that isn't a functional pump, flagellating basically, so there's no blood flow to the body. You don't maintain cerebral perfusion, meaning you don't have blood flow to your head and you go down. We call that a cardiac arrest. You can shock people out of cardiac arrest, which is basically the treatment you need really rapidly if that ever happens to you. But there's an arrhythmia that we see very commonly. It's something that increases every decade. Most commonly, start to see it in the 40s or 50s in a few people. It's called atrial fibrillation. And I just figured I'd spend a little bit of time on that disease because I'm trying to help you guys understand disease. You might have to see a doctor someday and maybe you'll have a little better baseline understanding. So atrial fibrillation is a arrhythmia, an abnormal heart rhythm that occurs in the top part of the heart, the atria, but it's not the sinus node that's generating the rhythm. You get a reentry rhythm in the atria, and it can happen in two different fashions. One's called atrial fibrillation and the other's called atrial flutter. In atrial flutter, the rhythm is about 300 beats per minute, and in atrial fibrillation, it's usually somewhere around as high as 600 beats per minute. Oddly, in atrial flutter, because the rate's slower, typically every third beat, sometimes every second beat, will get through and you'll have a rate of 100 or 150 in your ventricle. So that because it's in the top part of the heart, it does travel through a part of the conduction system known as the atrioventricular node. So the top part of the heart's still controlling the bottom part of the heart. And with atrial flutter, usually it's a regular rhythm, typically around 150. Atrial flutter, because the rate is so rapid, random beats get through, and it's typically an irregular rhythm, and the rhythm can be various rates, anywhere from low in the 60s or 70s, which is uncommon, to as high as 180. So the problem with this is, number one, the heart becomes less efficient. It's two things have occurred. One is filling times are not long enough for the ventricle to pump a bunch of blood. And the other is the top part of the heart's actually kind of just fluttering or fibrillating, which is super fast. So it's not pushing blood and filling that ventricle as well. So there's a reduction in cardiac output, or how much blood your heart is pumping to your body. And people will become symptomatic even if they don't notice the irregularity of the heartbeat. If you took your pulse and you were in atrial fibrillation, you would note it would be very irregular. You'd feel some strong beats. You might feel some really weak ones. If you took it in atrial flutter, it'd probably be regular and that rate of around 150 most of the time. And you might be able to feel the pulse pretty well, but it probably wouldn't be as strong as your normal pulse. We do have ways of getting you out of that rhythm relatively quickly. We can use electricity once again, but we don't do that all that commonly. There are medications that can be helpful. Some people will be chronically in and out of these abnormal rhythms due to structural changes in the heart, again associated with disease and poor quality aging, let's just say. And we won't be able to keep them out of that rhythm even with medications. And in that scenario, there's a significant increased risk of stroke. And the reason is because the top part of the heart is not beating, blood can pool and coagulate or clot. And when that blood clots, if the heart goes in and out of sinus rhythm, when it goes to beating again, the clot can be thrown into the ventricle and then go through your system and end up going somewhere else. And small clots can go up into the brain and cause strokes. So typically you will end up, if you have an episode of atrial flutter or atrial fibrillation, you will end up having the discussion of whether anticoagulation with a medicine that really significantly thins the blood and obviously has risks from that side of the equation is appropriate and will reduce your risk of death or stroke. There are ways that cardiologists, a particular type of cardiologist known as an electrophysiologist, can go in with the catheter again and actually try to find the area that's causing the abnormal rhythm and burn it. And it's pretty effective. I've had some patients that had very good control after that therapy. A little quick word about one other arrhythmia, really scary, not that dangerous. The name of that arrhythmia is SVT, or supraventricular tachycardia. Now, this is one of those things that is not really associated with disease, certainly not lifestyle type disease. This is a condition that I like to call bummer of a birthmark Hal from the old Far Side cartoon. The person is born with this potential for a re-entry rhythm above the ventricles, supraventricular. Again, this is an arrhythmia generated in the atrium, like atrial fibrillation and atrial flutter, except it's another pacemaker spot within the atria that goes really fast. Generally, the rate's about 180 to 220, and every impulse generally gets through the atrioventricular node, so the ventricle beats that fast. It still pumps, but it's pumping fast, and people know it. I mean, generally, people are symptomatic. It can happen in early adulthood or even younger, and it can be treated with medication acutely, but there are some maneuvers that we teach people once we recognize that that's the arrhythmia that they have, this supraventricular tachycardia. There are some maneuvers that increase vagal tone. The vagus nerve is a nerve that basically impacts how fast the heart beats, and vagal tone can be increased by doing things that increase the intrathoracic pressure. So we talk about a Valsalva maneuver. You can bear down almost like you're having a tough time going to the bathroom. You can cough really hard. There's another pretty safe thing that you can do, which is called the diving reflex. You can immerse your face in ice cold water. We don't recommend that patients try these other two maneuvers, but you can press on the eyeballs or you can massage one side of the neck at the carotid baroreceptor. And sometimes we can break the rhythm with that and teach people how to do that. If that's not effective, we have a very effective drug called adenosine that we infuse intravenously, a very rapid push of the drug, and it generally will break the rhythm. And then, once again, this is, if it's problematic enough, the electrophysiologist guys can go after the spot. But this is not a rhythm associated with kind of disease or the aging process. It's something you're born with, and generally it's not dangerous but scary, although obviously as you age and you develop more structural problems with the heart arteries, it's going to be tough for your heart to handle going 220 beats a minute. That puts a lot of demand on the heart, and so obviously that could get us into trouble. All right, so let me see. I think I'm going to leave the cardiovascular system now, and we'll move on to talk about something that none of us want to talk about. And I'm not going to dig super deep in this, but I'm going to give a general overview. We're going to talk a little bit about cancer. So thanks for sticking with me through the cardiovascular system. I hope it wasn't too much. I try to keep it simple. I want you to understand a better way to speak with your own physician or have more recognition of what's going on if you end up in an emergency room situation. But I don't want to overwhelm you with the data or the science behind this. So hopefully this is working out for you, and we'll move on. Thanks.